13th in the House Healthcare. And we are going to do a walkthrough and do some testimony on H266, which is still in the Senate. It's up for action tomorrow. So probably third reading Thursday. We should have it by next week, but there, barring anything unforeseen on the floor in the Senate, there's a new section in it. So I thought, or some amendments to it, I guess. So I thought we should start looking into what the amendments are. Jen, you want to come up and join us?
Good afternoon, Jen Carvey from the Office of Legislative Counsel. I will put language up on the screen. So I prepared a similar to what we've done for bills that have come back over from the Senate, but this one is showing markup from Senate Health and Welfare because the bill has not actually passed the Senate yet or been taken up. So this is H266. It is showing markup from the Senate Health and Welfare report. And so they did not make any changes in section 1. So just to reorient us, this is an act relating to the 340B prescription drug pricing program. Section 1 was where you had the provisions around manufacturers not putting any restrictions on covered entities' use of a 340B contract pharmacy. And so they did not make any changes, or Senate Health and Welfare is not recommending any changes to that section. So no changes till we get to section 2. Section 2 is the hospital reporting on participation in the 340B drug pricing program. And so they have there's a subsection B coming that's new. So I've made this one subsection A. Annually on or before January 31st, each hospital that participates in the 340B drug pricing program must submit to the board, and this specifies in a form and manner prescribed by the board, a report about the hospital's participation in the program during the previous fiscal year. And that goes on the Green Mountain Care Board's website and contains at least the following information. And the changes in this section are really the sort of, I would say somewhere between consensus and compromise, between the healthcare advocate and the hospital. So, so as you may recall, they were working on some of the language still when you were finishing up here, and so they came to some more agreement in the Senate. So striking out this first one, I think you're still going to get the information, but in a different way. So what you have in the House passed version is the annual estimated savings to the hospital from participating in the 340B program, comparing the acquisition price of drugs under the 340B program to group purchasing organization pricing. And if group purchasing organization pricing is not available for a particular drug, then they would compare the acquisition price under 340B to a price from another generally accepted pricing source. Instead of that, this would have reporting for prescription drugs that the hospital or any entity acting on its behalf obtained through the 340B program and dispensed or administered to patients during the previous calendar year. They provide the aggregated acquisition cost for all of those prescription drugs and the aggregated payment amount that the hospital received for all of the drugs, with information reported separately for each of the following distribution channels: dispensed drugs from an in-house pharmacy and dispensed drugs from a contract pharmacy, administered drugs paid separately, and administered drugs paid by bundled payments. So separate information for each of those 4 distribution channels. And then it just directs for administered drugs for which payment was bundled with payments for other services. Then the hospital must estimate the payment amount by comparing the actual acquisition cost for the drug to the wholesale acquisition cost for that drug. They suggest leaving number 2 as it is, aggregated payment amount that the hospital made to contract pharmacies. Leaving number 3 the same, the aggregated payment amount that the hospital made to any other outside vendor for managing, administering, or facilitating any part of its 340B program. Number 4 is struck, the number of claims for all prescription drugs the hospital obtained through the 340B program during the previous hospital fiscal year. Again, I think you get that information or the equivalent of that information under the new number 1. And then what becomes number 4 just changes, as you may recall, there was a bit of a conversation in here, some online, some offline, I think, about whether the term was savings or revenue. So in the Senate proposed version, the term would be revenue, a description of the ways that the hospital uses revenue from participation in the 340B program to benefit its community, et cetera. And then number 5, that was number 6, stays the same. And then there would be a new subsection B saying, because you remember that everything in subsection A is getting posted on the Green Mountain Care Board's website. And then B says, in addition to the vendor information required above, each hospital must also provide the board with a list of the names of all vendors that managed, administered, or facilitated any aspect of the hospital's 340B program during the previous calendar year, along with a brief description of the work performed by each vendor. And the vendor information reported under this subsection will be exempt from public inspection and copying under the Public Records Act and kept confidential, except the board shall provide it to the Office of the Healthcare Advocate, which shall not further disclose this confidential information. So they're split out because one piece of it is not public, the rest of it will be. Section 3 keeps the repeal, the sunset on the hospital reporting on their participation in 340B drug pricing program on January 1st, 2031. And then we get to some new sections. So sections 4 and 5 deal with the same language, but one takes it out and one puts it back in. This is looking at 8 VSA 4089J, which is in our health insurance statutes on retail pharmacies and filling of prescriptions. A couple of years ago, the legislature added this D4 that prohibits a health insurer or pharmacy benefit manager, PBM, prohibits them from, by contract, written policy, or written procedure, requiring that a pharmacy designated by the insurer or PBM dispense a medication directly to a healthcare setting or a healthcare professional to administer to a patient. This idea of a pharmacy designated by an insurer or PBM dispensing medication to the healthcare setting, and it's a medication to be administered to the patient, is a concept that is called white bagging. That's sort of a shorthand. And in the same act that enacted this ban on white bagging, it also had a ban on brown bagging, which is where the medication goes to the patient's home and the patient has to bring it into the healthcare setting to be administered. That's not being touched in here. So this language in section 4 would repeal the ban on white bagging, but it's going to be for a limited period of time because section 5 puts it back in. And so I'm going to slide down for just a second to show you that the putting it back in, reinstating the ban would take effect on January 1st, 2030. And then in section 6, this would direct the Green Mountain Care Board by January 15th, 2029. So the year before the ban on white bagging would go back into effect. Green Mountain Care Board, in consultation with DFR, would report to this committee and the Senate committee regarding the impact of repealing the ban on white bagging on hospital budgets, on health insurance premiums, and on health insurer solvency. And then section 7, again, restores, in subsection A, restores that ban on white bagging in 2030. Everything else would take effect on passage with the first hospital 340B report due in January of 26.
Any questions for Jen? I'm sitting here, probably people can't see, and talking about white bagging and brown bagging. Is there a polka dot bagging?
Not in here. There is white bagging, brown bagging, gold bagging, and clear bagging that I have learned about. So far, no polka dot bags.
Like I explained,
And
we repeal a ban.
then we put it back in.
Why?
So I think you're going to hear about that in the testimony to come. I think there's debate about whether the ban is the right thing, whether it makes sense to have the ban or not have the ban. So I think you're about to, right? I think
Yeah.
your other witnesses are gonna talk to you all about
White bag.
white bagging and whether it's the right thing to do, not the right thing to do. And so this is saying, I think the original proposal was to repeal, well, I know the original proposal was to just repeal the ban on white bagging. But there was interest in some parties in not having that be a permanent repeal. And so that's where it comes back in, which at a minimum allows the legislature in a few years on receiving this 2029 report to decide whether to extend that sunset to allow white bagging or keep it.
All this new language came from where?
Senate Health and Welfare.
Senate too.
Yeah, so this is all what Senate Health and Welfare has recommended. The bill is on notice in the Senate and will be up for action tomorrow. So none of this has actually happened in a way that would send it over to you from the Senate yet. So we'll see what actually comes up, but I think you're getting a head
So
start.
they haven't voted on it yet.
Senate Health and Welfare has the full Senate has not.
The Senate Health and Welfare vote.
I believe it was 5-0-0. People remembering that. They voted out two bills on the same day, and I think one was 5-0 and the other was not.
Yeah, I think they did 482 on the same day as 266.
Yeah.
All right. Thanks, Jen.
Sure. Now we'll get you the what. Just give you the what.
Keep it tight. So let's talk about white bagging, since it's been a couple of years since we talked about white bagging thing. Devin, you want to come on up?
Good afternoon. Devin Green, Vermont Association of Hospitals and Health Systems. Thanks for having me here today. I appreciate it. And I'm going to start off with the definition of white bagging, which Jen just gave to you, which is basically the insurer sends drugs from a pharmacy of its choice to a healthcare provider. They send drugs from a specialized pharmacy. This is not the typical, oral drugs that you can get on your doorstep or delivered to you by mail. These are specialty drugs. And as specialty drugs, they require a prior authorization, special care, special handling, a certain temperature, care coordination, and lab work. And what we were seeing back in 2022 were some safety concerns around this. So when we started off with the 2022 bill, we had a bunch of safety requirements. So we came up with a bill that would put out safety requirements about, sort of cold chain storage and just the way it would be delivered and the particular notice that healthcare providers would get about delivery and all of those things. But we ended up not having a very good enforcement mechanism for any of it. And so, we came up with the idea of, can we have health insurers sign some sort of affidavit or can they attest to the fact that all of this is happening and they're meeting all these requirements? And DFR said, we don't know how to enforce this. And so that's where we landed with the provider choice piece. Providers could say whether or not they agreed to having white bagging as sort of the quality control mechanism here. So we do oppose this repeal. And again, we oppose for the reasons I just stated in terms of concerns about safety and quality. Back in 2022, we would see delays in care because the drug was not delivered in time for surgery. We see delays in care because the patient's condition has changed and The dosage needed to be changed in response, but instead we have this delivery that has come to us. We saw administrative burden because instead of putting the order in through the EHR, we would have to log into a separate, let me see, e-prescribing platform. And we saw incorrect dosages supplied. We saw medication being delivered to mailboxes or put on desks. And in general, it does add to both patient safety and quality issues and then administration issues too, because we have our own sort of process and then we have to do a whole separate process from various places that the medication is coming from. So I would say number one, we would ask this committee to not support the repeal and allow for those safety and quality measures to be put into place. I understand there's a affordability argument here in terms of we can bring down the drug prices by allowing for white bagging. And so if the committee moves forward with this bill, and again, I could say you could not support the repeal. We could address the drug prices in the S-126 legislation where we need to do 2.5% of hospital savings, so, or operational costs. So that's one area that we could work on this issue without getting at the safety and quality pieces that white bagging brings up for providers. If you don't go the repeal route and you move forward with the repeal, we would ask that you maintain safety and quality requirements, have sufficient notice prior to implementation. Sometimes providers are not given a lot of notice when a drug is going into white bagging, and so they're unable to, create a workflow for the white bagging coming in. Have a patient-specific exemption process if white bagging is not right for that patient. Have same-day delivery so that if the patient condition changes, we're able to modify. 24/7 on-call access to a pharmacist or nurse so that we're able to get in touch with someone and talk about the medication. Cold chain logistics to ensure the medication is at proper temperature. I don't totally know what cold chain logistics is either. I'll be honest. I think it's just ensuring that it's like maintained at temperature the whole time from where it's moved and moved. Yeah. Demonstrate the insured designated pharmacy is accredited, demonstrate ability to deliver medications to a physician's office, hospital, or clinic in a clinically appropriate dosage and in a ready to administer dosage form. When we talked about these things back in 2022, Blue Cross Blue Shield and I think other payers testified that this already happens with the organizations that they work with. So they weren't necessarily concerned with meeting these requirements. Again, I think the issue is we don't have a great way to enforce these requirements. But I'm happy to work on that. And then also with white bagging, and the reason that we don't like white bagging is that it has an additional financial impact to hospitals and other providers because not only may appointments need to be rescheduled, but there's no reimbursement for intake, preparation, compounding, storage, administering, or I think there might be reimbursement for administering, but disposal of the medication, there's actually no reimbursement for that. And so we would, or oftentimes no reimbursement for those actions. And so we would also request that those services be reimbursed. We appreciate the report that would connect the change with this white bagging to a reduction in health insurance premiums or savings and the sustainability of Blue Cross Blue Shield, and also look at the impact of hospitals. And we would request that the sunset of the repeal be changed to July 1st, 2028. That is comparative to how long the 2022 law has been in effect. And, Blue Cross Blue Shield has come forward and has been able to show that this potentially has had an impact within these couple of years. So I think it's fair to say that we would see an impact in the other direction in the same amount of time.
You have a bullet in why you're opposing repealing it, saying that JAMA published research letter finding that white bagging results in lower payments to insurers but higher out-of-pocket payments for patients. Can you explain why, what that means, what?
I think there was like a very small sort of study that looked at the impacts of white bagging with the hypothesis of if white bagging reduces drug costs, then patients should see lower out-of-pocket costs. And the findings were that they did not see lower out-of-pocket costs.
Any questions for Devin? Go ahead, Leslie, and then Woody.
So I've heard over the years about how demanding pre-med care board is of hospitals and requiring information. And this is could be another example of a lot of information being required. What's your response to that?
In terms of the
Looking at,
report?
to whatever one. two.
We think that we support the request for information here, like the 340B information that we'll have to report. I think it's good to be transparent and see what the impact of these issues are. We really, really advocate for trying to find that connection between the policy and the impact on affordability, because that has been driving a lot of policy decisions. And so we want to ensure that that is actually happening.
So you're okay with
Yeah.
supportive, so we won't be hearing back from hospitals about yet another.
I can't guarantee that my members won't, but if you do hear back from them, direct them to me.
Thank you. That would be very helpful.
To further Leslie's question, we're talking about white bagging now, but is there anything else that the Senate made changes to after white bagging that you're?
Oh, were you talking
In
about the
agreement?
340B reporting, or were you talking, oh, sorry, I thought you were talking about the white bagging reporting. I came to agreement with the healthcare advocate on the 340B reporting. The hospitals really may complain about it, but you can direct them to me. That stands.
As long as I have,
Woody,
What type of medications are we talking about? White bagging?
Yeah, I think we're talking about cancer drugs, infusions, those sorts of things.
Very serious.
Mhm.
can you kind of give sort of a real world example of how it used to be in practice before we had the ban on white bagging? Or I'm not, at this point, I'm not even sure. Are we banning? Are we? Whatever we're the bans. So like, what was the logistics of before the ban on how hospitals obtained medications? What was the process in place? And then give an example of since the ban, what has been happening and why it's safer with the ban.
Yeah, I think for hospitals with white bagging, it can get chaotic for the hospitals. I think what we primarily heard about were complaints about not knowing when the medication would be there, not knowing where it would be. And then once we have the medication, and, difficulty storing it because you're having it come from all different places and it doesn't match into our system. And just having administrative difficulty. And then also complaints from patients about, having to change an appointment because the drug wasn't there on time or the dosage needed to be changed and miss an appointment that way. Or their condition changing because there was an improper dosage of the drug or something to that effect. So there were actual quality and safety concerns taking place at that time.
I think what I'm trying to ask, because I'm trying to get a sense of the flow. So previously, a provider would determine that you needed this specialty drug. They would e-prescribe it. And then what, the PBM, would it be going through the patient's pharmacy benefits?
Yeah, my understanding is it would go through the PBM.
And then the PBM would decide where they were going to get that for the lowest cost.
And they would ship it.
And then they would ship it. So when we banned that, do hospitals now just stock their own?
Yes.
Okay, so the doctors like, okay, let's infuse this. And they go in their EHR and then someone from down at the specialty pharmacy comes up with a cart and there it is.
Right.
Okay. Right. Go ahead.
Do you have a sense of the turnaround time then of that? Once it's ordered, once it gets to the patient?
I mean, we put originally in our proposed bill language back in 2022 that we wanted 24-hour turnaround time. So
PBMs that's doable.
I don't know.
it may have been taking longer, which is why we wanted the 24-hour time, but I don't know for sure. I think we just wanted to ensure that we would get it in 24 hours.
Does it go through the patient's medical benefits or does it go through their pharmaceutical benefits?
I don't know the answer to that question.
Do we have a, so this took effect in 2022?
Correct, July 1st, 2022.
Do we have a sense of hospitals' revenue generated from 340B or specialty drugs prior to 22 and then post implementation of the ban?
I don't have that, but Blue Cross Blue Shield might have more information.
Could the hospitals provide us with that
Can
information?
try to get that for you, yes.
That would be great.
Yeah.
Like individually, each hospital.
Okay, well, okay, I will try my best.
Right. Any other questions for Devin? Okay.
All right, thank you.
Next up is Sarah. Hey, Sarah.
Sarah Teachout with Blue Cross and Blue Shield of Vermont. I have a presentation that I'm going to share. And hopefully I can answer some of these questions for you. Make it bigger. There we go. So I start the presentation with a slide that you've seen in the past, and then I talked about the last time I was in here. And so trying to explain the problem that we're trying to solve. So this is a study that was done by RAND looking at prices for state level hospital administered outpatient drugs. So that's what we're talking about specifically. These are drugs that we were given intravenously or sub something or other. That's it. And they tend to be expensive drugs for specialized treatments, specialty drugs. And in this study, which was from 2020 to 2022, so it's a little bit dated, it showed that in Vermont, the hospital prices for these drugs are 5 times the average sales price nationally, and that Vermont is the highest cost state in the country. So by a considerable margin. So average across all hospitals is 280% of the average sales price. So Vermont's just extremely expensive.
Why is that?
I think because the hospitals have marked up the prices considerably. And when I say hospitals, I will be very clear that most of this is happening at the University of Vermont Medical Center, but it is happening across all the hospitals. We do see some outlier drugs prices at every hospital.
Do we have any idea what Hawaii's doing?
Yeah, like I
I do know what Rhode Island's doing.
Yeah,
That's the
but-
next state in. I'm
Okay.
not an expert on Hawaii, but someone sent me the bill that passed in Rhode Island, so I can talk about that.
I just think it would be more expensive to actually procure drugs in Hawaii.
So I showed you this slide also before. I have since updated the drug prices. So this is specific to the University of Vermont Medical Center. And these are updated average sales price as of January 1st, 2025. What I showed you before was 2024. So they've all changed a little bit. I'm no expert in these drugs, but you can see that the prices for some of these drugs is astronomical, to be honest. So 2,312% of the average sales price for Inflectra. It's an anti-inflammatory drug. The one for Kanjinti went down a little bit, but Neulasta went up. That one's 6,954% of the average sales price. Remicade went down. That's another one I had more details on. And then I can't say the last one.
Let's say Ruxians.
Yeah. Whoever names these drugs, I don't know. So that's a cancer medication. So those are the prices we're paying to the hospital for these drugs for our members. If we were to procure these drugs through OptumRx, which is our PBM that we use, they charge us on average, now it's not a flat price, but on average, 120% of the average sales price. So, and we looked, if we procure all of the top 50 drugs being used for our members, from OptumRx, we believe we could save $46 million. Now, we know we can't procure through white bagging every single drug. So that's the upper limit of the savings we could achieve.
Oh, yeah, I'm gonna go to Woody, but really quickly, because we've never really talked about this. Can you sort of explain? I mean, I know it seems intuitive, average sales price, but how is the average sales price determined? What does it mean? I want people to understand what ASP actually is.
Sure. ASP is determined by CMS, and CMS uses it for Medicare pricing. They update the price every quarter, so 4 times a year, every quarter. And I think it's based on, I would have to look into the methodology, but I think it's based on the average sort of sales price. It's pretty intuitive. That is being paid by commercial insurers for drugs across the country.
So it's not the wholesale price, it's not the price that the drug is procured
From the wholesaler.
from the wholesaler, it's the sales price.
Yes.
Okay. And Woody,
So this is UVM costs.
Yes.
Does Blue Cross Blue Shield have anything for our other hospitals for these 50 drugs? And how many of our other hospitals are actually providing these meds to patients?
Sure. I do have it. I just got it before here, so I'll
Okay.
be able to give it to you later because I knew that question was coming up. I can give you that. I would say that the majority of these are being administered at the University of Vermont Medical Center. These are, very specialized drugs for extremely rare conditions, a lot of them. But they are being administered at other hospitals around the state.
And would you say, I mean, you don't have your report with you, but how much more, how does it compare with UVM?
Right. So I'm going to say 2 things. On average, the other hospitals are charging less, but there are outlier drugs at every hospital where the prices are very high.
And we don't know why that's the case. I guess.
So hospitals control the charge masters and decide the prices for these drugs on their charge master. So every hospital is making a different decision. I don't know exactly why.
Leslie,
Just a clarification, 46 million a year?
Yes.
Okay, thank you.
Bert?
Could you just explain, if Blue Cross Blue Shield purchased the medications themselves, how would you do that? If I'm the person, I'm in the hospital,
Sure. Yeah, so we don't do it here in Vermont, but Blues plans across the country do this, and Optum Rx does this in about 45 other states. So you learn what the medication is the member needs. You have to communicate with the doctor about the dosage and the information. Then I'm giving you the high level, but it goes through the PBM specialty pharmacy. So the hospital has a specialty pharmacy. We also have a specialty pharmacy through our contracts. And so the specialty pharmacy procures the drug from the wholesaler, has it shipped to the hospital. They do have to do a whole level of communication to make sure that it gets there in time for the patient's appointment,
Right.
that, all the processes are followed. And then the doctor administers, or whoever the provider is, administers the drug to the patient at the facility.
and just out of curiosity, how is that process working?
In other states, my understanding is.
There's a lot of states doing it.
There are a lot of states doing it. The shipping is very similar to the shipping that happens when a hospital buys the drug. They're buying it also from a wholesaler that's shipping it to the hospital. These are,
You ship that to the hospital. Yeah, but do all hospitals have pharmacies?
no, all the hospitals don't have pharmacies, but they may have a contract pharmacy, a contract specialty pharmacy. That's the other part of the bill.
Yeah.
Hopefully I'll answer more of your questions as you go through. This also I presented to you before. Again, these prices are older than the ones I just showed you. So these are 2024 prices for 2 drugs. And I think the key points I want to see is we've compared the University of Vermont Medical Center. The second one is Dartmouth. Our team uses
Mary Hitchcock.
Mary Hitchcock Memorial. The next one down is community medical drug pharmacy. So a lot of these drugs aren't supplied in a community clinic, but they could be. A few of them are. And then Novella is a drug infusion center in South Burlington. So, like many other states have more of these, but Vermont has very few. So that's just an infusion drug site that we would send the drug there or procure it there. They're not used a whole lot in Vermont yet. And then Optum is our PBM pharmacy. So you can see the price difference between UVM, Dartmouth, and then these other sites for receiving the drug and having the infusion. And then the numbers over on the right, I can't see on my screen because there's other things in the way. We have information that compares the cost that Blues plans are paying across the country. It's just Blues data. I don't have data on other health insurers, but Vermonters pay, covered by Blue Cross and Blue Shield of Vermont, pay $32 more per member per month. So this is in your premiums, than the national benchmark for injections, infusions, drugs administered in hospitals. So that's reflecting the RAND data. This is our own internal data. And then this is the other really worrisome part. These costs are increasing faster, almost $5 per member per month faster than the national benchmark. So we have the highest prices, and the prices are increasing faster than the national averages here in Vermont. And so if you want to know how much that is in your premium, multiply $32 per person per month by 12. And that's built straight into premiums. And that's a huge part of the reason why premiums are so high in the state of Vermont. When we look at all the things contributing to high premiums, this is the standout reason for high prices.
Why is Optum so less expensive? Where is it? Where are these meds produced? Where is it located in the States, if it's even in the States?
So Optum is a middleman. It's a PBM, and they are buying the drugs from the same drug manufacturers and the same wholesalers that the hospitals are. The hospitals have an enormous markup. PBMs are in a highly competitive marketplace where they're competing with other PBMs across the country for for health insurer contracts. These hospitals, in part because you've banned white bagging, you've given us no other alternative to get the drug. We have no negotiating leverage at all, can charge any price they want for the drug because that's the only place we can buy it.
And we do not know what hospitals are paying for these meds.
True,
So
we
they
have some
could be-
ideas of what they're paying, but we
But they
don't
could
know.
be paying much more and then be passing it off to
So-
Blue Cross Blue Shield.
So it's unlikely they're paying much more. They're getting wholesale prices, and then many of them are using the 340B program to get additional discounts on the drugs. So we know they're paying less than the average sale price. And sometimes, in some instances, much less, on average 30 to 50% less than the average sale price.
Or the average wholesale price if it's a 340B drug, right?
I don't know if I put much in here about the prices that the hospitals have. I have some information, but again, because they don't report it, we don't necessarily know exactly. It's, kind
But
of,
you're assuming that,
well, we're kind of getting at it by what we know is happening in the marketplace and what we know that the benefits they get.
Before you go on,
Sorry.
I just want to remind the committee, just because it just dawned on me as I'm sitting here looking at the Keytruda, we actually received written testimony from a community hematology oncology practice in Chittenden County, I believe it was. And they were specifically, when we were doing the 340B, they were talking about the difference in the price that the reimbursements that they could get for the exact same cancer drugs that they're also infusing or giving that the hospital could. So I would, if everybody wants to, we can find it and maybe have it reposted to our, so there are community physicians who are doing this. And most likely their wholesale price is actually higher than the hospital, because they don't have the volume probably, or the 340B.
Exactly. I'd love to see that.
Yeah. Well, listen, I think we got written testimony when we were doing the 340B.
This is specifically to Remicade. Again, this is the 2024 price we were paying. I've updated, the new price is lower. But the thing about this chart and what we're seeing is that we know that the average sale price for Remicade has been dropping over time. And this shows it from 2017 to 2024. And the blue bar is the price for Remicade. But what we're paying the hospital has been going up all that time. So they're making just more margin on the drug. They're not passing any of the savings on to the insurer or to the patient. That's I think the whole point of that. And the other thing we would note is that the price increase for this drug pretty much matched what the Green Mountain Care Board was approving for hospital budget increases over the same period of time. Again, I showed you this chart before, so it's a little bit of a repeat.
Do we know how much it went up?
And it actually went down.
In 20, no, I'm thinking about from 22 to 23 when the ban on white bagging took place. Did it go up 225%?
Yeah, so we've seen it more tracking with the Green Mountain Care Board budgets than any major jump in 2022. Blue Cross and Blue Shield of Vermont did not white bag before. It was something we were considering because of the high prices, but we weren't actively white bagging any drugs for our members in 2022. So this is some quick, and I won't spend a lot of time. What the hospital does is called buy and bill. And this is the traditional approach. They determine which drug their needs. They order it from their in-house specialty pharmacy, and there's some nuance there. And then it's delivered to the patient in the clinical setting. It's all kind of contained within the hospital and their administration. It does allow the hospitals to choose the drugs for their patient where the hospital makes the most margin. And we see that in the data. So maybe there's 3 or 4 brand drugs that have a similar clinical outcome. And oftentimes the hospital picks the drug that the hospital makes the largest margin.
I'm sorry, go ahead.
It feels like we're experiencing a new rendition of squeeze the balloon game. So trying to remember when we passed in another biennium, the PBM bill, the ban on white bagging was directly related to a couple of things, the concerns that Boz presented around safety issues. But that also that PBMs were utilizing and directing prescriptions to their own specialty pharmacies because they could direct to the highest price medication. So this just seems like a different version of that same game, and just something for discussion in the committee. I'm interested in how I'm hearing and recognizing the data from what you're presenting, what we're seeing from the hospital issue. So I want to just be careful in this bill that somehow we have, whether it's the care board, it's likely the care board, are preventing this from happening, whether it's a PBM or whether it's a hospital or any other entity. Thanks for that.
I completely agree. There's a lot of incentives that are financially motivated especially in the drug space. So
Yes.
they're just different for the PBM, for the hospital, for all the different entities. I think acknowledging that they're there and understanding what they are will help you make the right policy choice. I hope. So just a few other terms. I want to explain white bagging again. You heard that one a couple times. So clear bagging. Clear bagging is not banned in the state of Vermont. Clear bagging is when the hospital's internal specialty pharmacy that's on the retail side fills the patient's prescription, obtains the 340B discount, and then delivers the drug to the outpatient side of the hospital for administration to the patient. So it's a little bit analogous to white bagging, but it's happening internal to the hospital. So in hospitals, there's two ways that drugs are priced and delivered to the patient. One's on the medical side and one's on the retail drugs. So if you've been, not all hospitals have retail pharmacy clinics, but if you've been to our academic medical center, they have a retail pharmacy in the academic medical center. They can write your provider can write you a script and you can go over there and fill the drug as if you were at any pharmacy right there in the hospital. So that is their retail pharmacy, and that's where they're obtaining the 340B discounts. So the reason that a hospital, and I say here, there's an incentive. Hospitals may be incentivized to shift to clear bagging because of the 340B product discount. So when they run it through the medical side, I don't think they get the 340B discount. It's only if they clear bag. Brown bagging, you've already heard, that's when you deliver the drug to the patient. We're not asking to change that. And I do believe there are probably more safety concerns around that. And then site selection is another thing you'll probably hear coming up, but it's when the insurer who's paying decides where the patient has to be administered the drug. And so some insurers are saying you can't go to the hospital to get this drug infusion. You have to either do it in a local clinic or at a drug infusion site. It's not an option that works very well in Vermont because we don't have that many other sites of care. But there are bills in other states around that as well. Okay, so I just wanted to provide this information about the Drug Supply Chain Security Act. So this is a federal law that mandates that drugs are tracked from the drug manufacturer all the way to the patient through the supply chain at the individual package level. So there is, and I'm no expert in this, but there's a pretty robust mandatory process for tracking drugs in the supply chain. There's all kinds of reasons. One is safety. The other is, counterfeiting, diversion, contamination, lots of reasons why we really need to track drugs, very closely in our supply chain. So that's in place and is already in place. Medicare also allows white bagging for specialty medications. So if the medications are covered by Medicare Part D, which is a commercial health insurer, they can be white bagged and they're billed on the pharmacy benefit. If the drug goes through Medicare Part D, then it's buy and bill through the hospital. So there is some allowance in current Medicare to do this. I think that this is the most updated list of states and how they've handled white bagging. I could be wrong. I was doing a little online research and I think this is what I've got. But Arkansas, Louisiana, Utah, and Vermont, I believe, are the states that ban white bagging outright. And we were one of the early states to do this. Other states restrict white bagging, which is more nuanced. So Minnesota, Rhode Island, Texas, and Virginia. So they have more guardrails around white bagging, but they don't outright ban it. And then this is some information I got from OptumRx, our PBM. They shipped 18.6% of all their prescriptions to the providers. They ship medications only if there's consent from the patient and coordination with the staff at the office. It's costly to the PBM to ship these medications as well. They don't want them to be, and they have requirements that they track and keep care of the drugs. Some people have asked the difference in how the product is packaged. There's no difference if it's shipping from the PBM wholesaler or the other wholesaler. It's really based on environmental considerations. How cold is it out? How hot is it out? And the transit time to pack and deliver them. They have their own quality insurance internally through audits. And then they did note that if the product that's shipped requires what they called additional manipulation, so apparently reconstitution of the drug, dilution of the drug, moving the drug to temperature, there's lots of things I don't know about, that the process is completed by the end user. So that's just the background on white bagging. And so I think before I jump into this part, I will say that Blue Cross and Blue Shield of Vermont has not white bagged in the past. We feel compelled to do this because of the prices that our members are paying for these drugs, and that we need, everyone is looking to us and to everyone here to get their arms around the price of premiums and affordability in healthcare. And that if this will help our members and our patients get their drugs in a way that's more affordable, we need to start doing this. There are other states that have done it different ways. But I just wanted to give you some information about average sales price. So I mentioned already that CMS is the source of average sales price. And if you have this online, you can click that and it's a link to their website. And the average sales price is widely used as the benchmark for Medicare Part B and Medicaid. So their drugs are all keyed off average sales price. And then I got this information from Nancy Hogue in our office, who used to work in the Medicaid program. So Medicare pays 106% of ASP, except for some biosimilars that they pay more. Vermont Medicaid pays 98.5% of average sales price. Remember, there's still a markup above the wholesale price. So even if it's not 100%. And we pay community providers, Blue Cross and Blue Shield of Vermont, 110% of the average sales price, acknowledging that not a lot of these drugs, but some are administered at community providers. So I think I've already said this, but Vermont hospitals set the prices for drugs administered in the outpatient setting through their charge masters, and outpatient drugs are not paid for in DRG or bundled arrangements. I had heard earlier that some hospitals said they didn't know what the price was because it was part of a bundle. We're not paying, at least Blue Cross is not paying for outpatient drugs in a bundled arrangement at all. We do for some inpatient drugs. And then I think I've already talked about the retail pharmacies that are within hospitals that go on the retail pharmacy channel. And so when a hospital fills a script at their retail pharmacy for a Blue Cross and Blue Shield of Vermont member, it tracks in our benefits system as if they were a contract pharmacy like any other pharmacy out on the street. So it runs through the pharmacy benefit, which will be important later, versus the medical benefit when you get a drug in the outpatient or inpatient setting. It's paid for on your medical benefit, so it's in your medical policy, which is a little complicated, but I'll get to the reason why I have to say that.
Can you repeat that? Like,
Yeah.
Are you talking about an inpatient that then or they're
It
discharged?
depends on how the hospital's billing the claim, but if it's an inpatient or an outpatient claim and it has drugs in it, it's billed to us as a medical claim and we pay for it through your medical benefit, and all of the rules and that apply to medical benefits apply. So there's a cap in the overall amount that you pay out of pocket for medical benefits. It's set by the ACA, and that applies on the medical side. Vermont has a specific prescription drug cap that only applies on the retail side. So it depends on where you procure your drug, how this impacts your out-of-pocket costs.
So a patient that's inpatient is being discharged on this today, and part of their discharge, they need to pick up some new medications, either at their home pharmacy or at, I'm going to say UVM.
Yeah, it has nothing to do with the discharge. It's
Because they go to an outpatient pharmacy, that would not count that wouldn't be an inpatient or medical, billed under medical.
right.
Okay.
Yes, I think I'm tracking with you. But if they had received the drug as a inpatient or outpatient on the outpatient side, then it would be billed on their medical claims.
Go ahead.
We talked about reference-based pricing in the previous bill.
Yes.
Why hasn't it been suggested that we just do reference-based pricing on these types of drugs based upon, I don't know, the Medicare or Medicaid pricing? I mean,
Yeah. That's one solution. So rather than base it as a percentage of Medicare, you'd probably use what Medicare does and do as a percent of average sales price. But yeah, this is
and do you know what your savings would be based upon that?
So on average, we pay 120% of average sales price for these drugs actually, it just depends on what number you pick. Sorry. That's what we're paying to our PBM.
And like this probably would go to Devon. But would our hospitals be in favor of something like this for this?
Devin Green from Buzz, I would want to discuss it with our hospitals. There are affordability initiatives going around, and we would want to analyze how this would fit into that.
And presumably, the hospitals could make a wee bit of profit, maybe.
Mhm.
If we went through that, but I'm just thinking outside the box.
I appreciate that.
How, just carry that further. How would you do that under reference-based pricing?
I don't know, I'm just asking.
Okay, I thought you had a.
Yeah, no, I don't, I just, I mean, if we're trying to keep the costs down for our medical care, why wouldn't we extend it to our pharmaceuticals as well within the hospital?
So just a couple responses. I like the way you're going. The one thing I would say is that reference-based pricing is a couple-year process. I think the Vermont legislature could decide what the reference-based price should be for these drugs and do it now and get the savings for your.
And I'm not advocating for Blue Cross Blue Shield.
Yeah, no, I know. So these are just, I tried to compare the differences between white bagging and some sort of cap of the average sales price, which is essentially a reference price. And I think the one thing you identified is a big concern for Vermont. If Blue Cross and Blue Shield of Vermont starts white bagging, the margin made between the wholesale price, whatever it is, and the price that the commercial health insurer and the patient pay, that margin will move to our PBM. So Optum Rx will make the margin on that drug. If the hospital fills the script through their channel, the hospital makes the margin on that drug. I think we all have a vested interest in keeping our hospitals, sustainable. And so that's one choice here. If the hospitals would agree to lower the price, they can keep a reasonable margin, right? So that's one idea. Some ways I'll just jump in and tell you that Rhode Island said that the hospital has to accept the equivalent price, and I have the statute, that the insurer's PBM pays for the drug. So it makes it so it's no different for the insurer to white bag versus just pay the hospital. And so that's how they did it in Rhode Island. So the prices are all over the map because every insurer has a different price negotiated with their PBM, but it says that the insurer won't pay more than that price to the hospital.
So that means the PBM is dictating the price.
Well, our contract with the PBM would dictate the price. Yeah. Or if you capped it, here in Vermont, you would control the price. So there's different approaches. I will also say that, again, white bagging is complicated. It adds a level of complexity to the system that we're not thrilled with, but we really believe the savings are important for our members. What we would first do is try and negotiate with the hospitals. Rather than immediately white bagging, we would say we can obtain the drug for our member over here at this much lower price. Would you negotiate with us a lower price? I think we would try that first, but there's no guarantee. But that's where we'd end up.
So the reference-based pricing, we wouldn't have to go to that.
We believe that through white bagging, we can safely deliver most medications to the hospital for most patients. It may not, and I spoke at length with Nancy Hogue, our in-house pharmacist, about this. She thinks it may not be appropriate in every situation. So that's why I said the high estimate is 46 million. If we were able to white bag every single script, we probably can't. So it would be some number lower than that. The example that she gave me was on a lot of oncology medications, you want to make sure that the medication works for the patient first. So what a lot of PBMs do and insurers is they let the hospital buy and bill the first dose of the drug, and then they white bag all the remaining doses as a way to save money. So once the patient, the provider and the patient have determined that that is the right medication for the patient's situation. So the 340B piece, I'm just being very transparent here. If we white bag, if a health insurer white bags, we get the rebate on the drug from our PBM. When the hospital fills the drug, and we see this at UVM, if they're using their 340B program to purchase the drug, we lose the rebate and the hospital gets the extra margin. So there's a shift there in who benefits. We pass 100% of our rebates on to our members in lower premiums. We have seen a loss of rebates in recent years because the hospitals, especially UVM, are making more use of their 340B program, leading me to believe they're getting lower prices for the drugs because they're using 340B. And there's a study I can show you about the percentage of drugs being filled through 340B at different hospitals. And so the prices are going up for our members, not only because the price being charged to us by the hospital, but also because the loss of rebates through our PBM. I can explain more if that doesn't make sense. And then this is the piece, benefit coverage and out-of-pocket costs. So when we white bag, the price of the drug is processed as a retail pharmacy claim through our PBM. And so the patient, the member pays the out-of-pocket costs required for retail drugs. And it also falls under the drug-specific cost cap here in Vermont. So Vermont's the only state in the country that has a price cap only for the drugs you pay over the course of the year. All other states have the medical and pharmacy drug cap that applies across the ACA marketplace. So over on the other side, if the drug is filled by the hospital through the medical side, and that's how we're paying for it, then they fall under that cap. So the patient, and I think this is why some of these studies are showing different things. The patient could have a different out-of-pocket cost depending on how the drug is procured. And it's because we have kind of a complicated, wonky system here.
You know, that's one of my pet peeves.
I do know. And this is a place where it actually plays out in real life and affects people. And then the difference between our PBM at the hospital is on average 120%, but we don't pay 120% of ASP to our PBM. It's a different price for every drug. That's just the average across all the drugs that we get through our PBM. If you were to do a cap or a reference-based price, it would be even across all insurers and all patients in Vermont. It would be much more equal and easy, transparent, easy to understand. So pros and cons to each of these things. I'm sure there's things I've forgotten. I did send you also a study. It's very long. I'm sure you don't have time to read it. I only got 2/3 of the way through. It was done by ICER, ICER. I think they are a kind of a neutral research organization, and it talks all about white bagging, brown bagging. And then way down on like page 127, there's a chart of different proposals for policy proposals for how states can address these. And one of them is to cap the price. So that's one of these, their proposals for what to do, among other proposals.
Questions?
Rhode Island. Can you find out about that?
I have the bill. I can give it to you.
I'm
Is there,
curious.
is there regulation in that bill?
So there doesn't need to be any regulation. It says that you can't white bag, but the hospital can't charge any more than the insurer's PBM price.
So we'll give okay, I'm gonna call it profit and people can argue with whatever, but essentially, so what they say is whatever the PBM would have profited, we're gonna let the hospital profit, but no more than what the PBM would have. Which is what, as you're going through your testimony, I'm thinking back to when we did this before, because the goal was PBMs were benefiting. And I think when you look at this, I mean, frankly, it's kind of depressing, is somebody's always gonna be making money on the backs of Vermonters.
Welcome to capitalism.
Sarah, I actually do have a question about, I know that we concentrate a lot on, some of these rarer, I'm gonna call it egregious. Can I use the word price gouging? I think when you're at 2,000% of average sales price, that's price gouging. But do we have a sense of where hospitals are just in terms of some of the more commonly administered drugs, higher utilization? I mean, I'm thinking about saline. Sure.
It's not a drug.
Well, no, but it is actually a drug.
It's considered a drug.
It's considered a drug. And, your markup may not be like glaringly 2,000%, but when you're talking about the volume, how much money is being made off of, we're just looking at specialty drugs here, correct? Yeah. Do you have any sense of
I can ask,
they use drugs?
I can ask. We looked at the top 50. I think they were the most, like the drugs that we spend the most money on, which can either be an outlier, really expensive drug or a common drug that we just, spend a lot of money on. So let me ask, but I know we looked at kind of the top list of drugs that are our highest spend. I'm not sure if saline would fall into that, but I can ask.
No, it wouldn't be the highest spend, but I'm thinking if you were billing 1,000,000 bags of
Pass.
saline, that even if it's marked up a little bit, you're still making a lot of money off that 1,000,000 bags. I don't know how many bags.
I'll
of
ask.
saline.
I don't know.
Well, if it's $1, you're making $1 million.
Thank you.
Thank you.
Thanks so much. You guys want to take a break here for 10 minutes? Back here at 2:30.